Good afternoon, everybody. We welcome you officially to this session. This echo session on emergency management of acute abdomen by Seed Global Health. My name is Hissa Marijan, registered nurse, an EMT, emergency medical technician working with Zimbabwe Regional Emergency Medical Services. Here with the team, I'm with Dr. Olinga. Can introduce himself.
All right. Thank you very much, Hissa. I'm glad to be part of the echo session again today. And I'm Dr. Daniel Olinga, an emergency medicine resident in my final year. Thank you very much.
Okay. Dr. Kakoza, you can introduce yourself.
Thank you. Good afternoon, team. I'm Dr. Kakoza Francis. I'm a surgeon working with Kawunga Regional Referral Hospital.
Our another panelist, Dr. Ronald, is online. He can also introduce himself. Yes, Dr. Ronald. Dr. Ronald. As we wait for him, Madam, you can introduce yourself.
Good afternoon, colleagues. It's a pleasure to be here and participate in this session. I understand you've been having a lot of fun in the previous. So I'm just here to talk about the certificate that you'll be receiving. As you know, most of you have been asking about your certificates, as we had promised that once you attend, you complete the phase, you'll be able to get a certificate. So this certificate will be available for those who have done 5 of the 7 sessions under the trauma phase. That will be 75% of the session. That's how your certificate will look like. A form has been sent out to you to fill. I hope all of you have filled it. And once we are done, you should be able to receive this certificate in your email. But as always, in case you have any challenges and you're not able to receive it, you can always contact us and we shall be able to find ways of ensuring that you receive your certificate. So similarly, as we start this new phase, we shall also provide certificates again for those who participate 75% of the sessions. So really encourage your colleagues to have that consistency so that you'll be able to get your certificate. Yeah, thank you, and I look forward to the session.
Okay, thank you so much. We have a pre-test. You can go in and answer the pre-test. Choose the answer of your choice. It's a multiple choice question. You answer, then after finishing to answer all your test, you can go down and submit. As we are waiting for that, we need also to get your expectations from all the participants. You can just type them in the chat room, and I'll be able to see them so that we can air them out. Okay, members, you can send in your expectations in the chat. Then as we wait for you, I would love to hear from our panelists, our experts. Dr. Olinga, what do you really have for us today about this session?
So thank you once again, Mr. Hissa. Every eco session presents us with better opportunities. And again, today's session is really picking into the emphasis of a joint or teamwork, because you cannot manage this as an emergency personnel alone. You need various departments to come on board. You might diagnose something because, as we shall see later, the symptoms that the patient present with are not so specific to certain illnesses that you might think at that point, and hence consultation and in a timely manner is very key. So I believe members online, the audience will really appreciate at the end of this session some of those key aspects.
Thank you so much. That's from Dr. Olinga. Dr. Kakoza?
Yes, thank you, Hisa.
Yes.
Like my colleague Dana said, every eco session gives us an opportunity to improve on our knowledge and how best we can manage the patients better. We are looking at basically management of acute abdomen in an emergency setting. So we are looking at the emergency department per se.
Yes.
For this particular session, our emphasis is going to be basically around the emergency. That's why we are not looking at particular illnesses per se causing acute abdomen, but we are going to look at acute abdomen in general and how best we can easily tap from the symptoms the patient presents with, the signs from the patients, and how best we can clearly diagnose, how best can we resuscitate this patient, and if the patient needs a referral, how best can we do this timely referral, and for those that can be managed, how best can we manage them, at least within an emergency setup. Thank you.
Okay, thank you so much, Dr. Kakoza. Mayanja Christopher says he's expecting to know much about management of abdomen. Fahad Kayuza, a generalized conservative approach for acute abdomen. Bushara Wilberforce, I expect to improve my management skills of patients with acute abdomen. Yes. Then Danet Tinei Makanda, a quick but easy way to assess and manage acute abdomen. Mugisha Godfrey says first aid, that's emergency care for a person with acute abdomen case, making a post-diagnosis of common causes of acute abdomen before imaging. How and when to decide on referral for an acute abdominal case. I think that's all we have for now. Robert Edilu, electrolyte imbalance, its prevention and management in a patient with acute abdomen in emergency setting. Elizabeth Ndikau, differential diagnosis of acute abdomen. Caroline Nampeo, learn prioritizing patient emergency nursing care in relation to presenting complaint. I think that's enough. Oh, one more. Yeah, this one is saying appropriate emergency approach in managing acute abdomen. I think it's just rotating around there. I think that's enough. So I don't know if Dr. Sally is online. Dr. Sally, can you hear us?
Yes, Doctor. Okay, so we wanted to share the results of the polls.
The polls?
People have answered different questions.
Okay.
We have had around 72% people who have responded, and for question number 1, which says which of the following is the most common cause of acute abdomen in the emergency medicine setting, 83% have chosen appendicitis, and then a small percent, 1% have chosen diverticulitis. So as the experts go into the session, you know where to concentrate your efforts. Then question 2, which says which of the following imaging studies is most appropriate for a patient with suspected acute cholecystitis. 67% have chosen ultrasound, but also a significant percentage, which is 23%, they've chosen a CT scan. And then a smaller percentages have chosen MRI, 7%, and X-ray, 3%. So as experts you're presenting, you have to talk about that. Then question 3, which of the following is not a common symptom of acute pancreatitis? And 63% have said bloody diarrhea is not common. Is not a common symptom of acute pancreatitis, and then 25% say jaundice. Then other smaller percentages say severe abdomen and nausea, but the main percentage says bloody diarrhea. Then question 4, it says which of the following physical examination findings is most suggestive of a surgical emergency in a patient with acute abdomen? Around 84% say rebound tenderness suggests a surgical emergency, and then smaller percentages chose other answers. Those that have not been able to respond to the polls, maybe you keep onto the session, you respond to the post-test polls. But let us pay attention. Back to you, moderator.
Okay, thank you so much. Thanks, members, for doing the pre-test. Next on the agenda is our case presenter, Dr. Sally Ronald, who is going to present our case, which is the main discussion of today, on acute abdomen. Yes, Dr. Sally.
Yes, Doctor.
Yes, please, you're online. The participants are with you now. You can share with them. You can present the case to us. You're welcome.
Good afternoon, everyone. I am Dr. Sally Ronald. I'm working at Naguru, China, Uganda, and also I work at Montana Medical Chambers. I'm going to present acute abdomen as the case presentation. And next. Our patient, some simple biodata. It was Mr. Opti, a 3-year-old male, Catholic, and naturally who separated the casual bala from Nagul go down Nakawa. That was a 63-year-old male who had long-standing history of ISS on TLD for 8 years, presented with a 2 days history of severe generalized abdominal pain that was of sudden onset, associated with bilious contents and passing and failure to pass stool and flatus, and also had anorexia. It was exacerbated by eating
lying flat or spine on bed, and by sleeping on the lateral position, flexed, or taking unknown painkillers. However, patient reported normal micturition habits and no history of weight loss. He also reported a 2 days history of low-grade fever that was of gradual onset and no associated convulsions. Significantly, the patient reported being managed for PUD for about 1 year on omeprazole.
Dr. Ronald, you're currently mute. You can unmute. Unmute.
Yes, I've unmuted.
Yeah, yes, please. We can hear you now. You can communicate.
Yes. So then on assessment, using ABCDE, the airway and the spine, the patient was able to talk and support his neck. Under breathing, the respiratory rate was 40 cycles per minute, SpO2 of 92% at room air. The chest was moving symmetrical and moving on respiration and with normal breath sounds. So what we did, we blocked up the bed. Then the saturation, the extremities were warm with no pallor, tachycardic with 109 beats per minute, and the pulse was strong. The BP was 104 over 64 millimeters of mercury. The capillary fill was less than 2 seconds. So at that time, when we gave fluids, 3 liters, normal saline, Wenger's lactate, and the D5. We also gave D50 for 10 mils at the admission. Then disability, the GCS was 15 over 15, and the PPs were equal and reactive to light. Exposure, on exposure, the abdomen was moderately distended. Absent, there was guarding and empty, there was empty. So the patient, we passed in G tube, given IV paracetamol, 1 gram for the pain, and then we gave IV omeprazole 40 milligrams start, IV ceftriaxone 2 grams start, IV metronidazole 500 milligrams start, and then we put the catheter. And then on the sample history, excellent. We had a general abdominal pain with bilious vomiting, failure to pass stool, status and anorexia, red fever, with auxiliary temperature which was 38.0, king of jaundice and dehydration. Reported painkillers for 2 days, and also the patient was on heart TLD for 8 years. Under past medical history, patient was seropositive, HIV seropositive for 8 years, and there was history of being managed for PUD, history of surgery done on him. The last meal, he last ate 2 days ago. And then the events, there was no events surrounding that. So our diagnosis, one, we're quelling a gut perforation, quelling pause, which was we have been managed for the period. Was intestinal obstruction, acute cystitis. The fourth one was acute cholecystitis. And the fifth one was acute appendicitis. So under our investigations, had a leukocytosis of 24, and the neutrophil count was 13. HB was 11 grams per deciliter, and the platelets were normal, 100. So under the liver function test, we did the creatinine was also 19 milligrams per deciliter normal. And was fine. We're able to do an erect abdominal other tests because the patient was unable to raise the funds to buy. People are saying my network is so we're unable to do the chest X-ray, the ultrasound scan, any other blood tests because the patient was not financially okay. Next slide. Management. Under the management, we manage conservatively. We gave IV fluids, 3 liters, at the ratio of Ringer's lactate, normal saline, and D5 in 24 hours. We gave IV D50, which was 40 mils, 6 hourly. Then we inserted the NG tube to decompress the abdomen. We catheterized the patient. I gave IV omeprazole, 40 milligrams OD, IV ceftriaxone, 2 grams OD, IV metronidazole, 500 milligrams TDS, and then IV paracetamol, 1 gram TDS, and IM tramadol, 100 milligrams TDS. The surgical management. The patient, we called in, the surgeon came, reviewed the patient, and we consented. We consented the patient, and we informed the theater. An emergency X-lap was done, and we found a perforated gastric. We did a Graham's patch, whereby the omentum was pulled towards the perforation, and a peritoneal lavage with warm saline was done. We used about 2 to 3 liters warm saline to lavage, and then the drain was inserted after the operation. On the follow-up, post-op, the patient was on nil per os for about 72 hours. We put the patient IV ceftriaxone, 2 grams OD for 5 days. IV metronidazole, 500 milligrams OD for 5 days. IV omeprazole, 40 milligrams OD for 5 days. IV fluids, 3 liters, fingers lactate, normal saline, and the D5 at a ratio of 1:1. Then we gave the IV D50, 40 mils, 6 hourly. A patient was given IM tramadol, 100 milligrams TDS for 5 days. Then on the 3rd post-operative day, the patient was introduced on oral sips. That was warm, was initiated on tea. And then patient was discharged on the 6th post-operative day. Thank you very much for listening. That was our case.
Okay, thank you so much, Dr. Sally, for the case
Yes.
well presented. For the participants, I would love you to ask, or if you have any query for our case presenter, you can raise up your hand or type them in the chat and echo them out. But for the meantime, I would love to hear from our experts. I would love to get your reaction on the case presentation, if you really have some questions and some concerns from our presenter. Let me start with Dr. Olinga.
All right, thank you very much, Mr. Hissa. I think it's a well-presented and a carefully selected scenario for us to kickstart the discussion with regard to the acute abdomen. And I love the fact that he even details for us some key parts of the management, which we shall still highlight further, but this patient benefited from them. The differential diagnosis is also rich, and from the patient's presentation, yes, he has a history of peptic ulcer disease for that given duration that he had. And now he has features of potentially gut perforation or intestinal obstruction. And I love the fact that he queries all those things. And you also have to query a complication that can arise from the two, potentially like peritonitis. Then given the symptoms that were also presented in abdominal pain, jaundice, then the fevers, it was very important for which he brought out that he presented for us that the patient potentially had appendicitis, had cholecystitis. So it was really a comprehensive picture that we shall delve into in further detail while we are discussing.
Okay, thank you so much, Dr. Olinga. Dr. Kakoza.
Thank you, Mr. Issa, and thank you, Dr. Sally, for our presentation. The presentation that we just presented, Alisa basically covers most of the things we would have loved to hear from a case presentation. Yeah. Maybe important to note the issue of when you went into the differentials. This is for you, Dr. Sally. I think before we talk about the intestinal obstruction, the picture is more of a peritonitis. So we would have loved to first give us the differentials of peritonitis before we go into the issue of intestinal obstruction. We understand as the obstruction progresses, there's a possibility of getting a peritonitis, but for the purpose of this discussion, we would have loved to see an appendicitis somewhere closer to a perforated PUD. But otherwise, thank you. Important to note for the presentation, selecting an elderly patient is good because most of the presentation is vague. It's atypical. Yeah, so possibly that could give us the reason as why the patient presented after 2 days. Maybe the symptoms were not clear at first. Otherwise, thank you. We are going to have a look at most of the issues raised in the case presentation as we progress.
Okay, thank you so much. From the chat, Mawem M. Arik is asking why bilious vomiting a gastric perforation. I think the experts will react to that. Kathe Nakanuaji is asking why tramadol is used and yet etanopoet, which affects gastric motility. That's her concern. I think that's enough. We can react to that. I would love to hear from the expert. You can maybe react to these two queries. From Mawemi Arik is asking why a bilious vomiting in a gut perforation.
This is a patient presenting after 2 days. You've noted that he was not passing bladder and stool.
Yes.
And he had signs of peritonitis.
Yes.
With peritonitis, there's a possibility of having a paralytic ileus, which is also a cause of a dynamic obstruction.
Yes.
Yes, I understand that. What's the question?
Why bilious vomiting?
Yes. Maweke could be wondering.
Arik.
Malik,
Yeah.
that the patient has a perforation and things are moving out.
Yes.
But if you look at the diameter, of course I was a part of the team that operated, but oftentimes it's rare to find a perforation which is more than actually 1.5 centimeters. So don't expect that in case of an obstruction due to a made a paralytic ileus.
Yes, please.
Don't expect that all things will move through the perforation then back to the peritoneal cavity. Definitely, in case of an obstruction which has progressed with ileus, there is a possibility of presenting with vomiting. But even in gastric irritation alone, it causes nausea. Yes, the gastric irritation alone causes nausea. So with nausea, you can have vomiting.
Okay.
Yes, and with vomiting, and you have an obstruction somewhere,
okay,
definitely you can have.
Dr. Daniel, I think you can react to Kase's question.
Okay.
Why tramadol?
Okay. So thank you very much, Dr. Francis, for that response. So why tramadol? Many a times patients are going to present to you with pain, and you don't want this patient crying out to you when you're using weak analgesics. So emphasis is we always want to follow through the analgesic ladder. So we start from the NSAIDs and acetaminophen. Then if the patient has not improved, we then progress to the weak opioids, where the codeine and the tramadols come in. Now, she emphasizes the point that there could be slowed gut motility, but we're also looking at that these are weak opioids, and slowing of the gut motility is dose dependent.
Yeah.
So the patient who has presented to you acutely, you have to relieve their pain with the agents that you have. But it's if you use them for a longer time, maybe weeks even, that is when they will start presenting to you symptoms of slowed GIT motility. But for this particular case, I think because of the pain the patient had, it was really a good place for them to use tramadol.
Okay, thank you so much. I think just one more. This is interesting. Gibson Bale is interested in you talking about chewing gum post-operative to manage paralytic areas. To use chewing gum post-operative managing paralytic areas. So I don't know if you have something about it.
There is a book, a paper is enhanced recovery after surgery. One in studies have showed that when you chew chewing gum,
Yes.
that alone increases the gastric motility.
Yes.
But we also advocate for early feeding in addition to chewing gum. But of course, the issues with chewing gum, you can find that a patient may start complaining. Yes, that might push the patient into taking oral sips. Yet would they have loved to. But of course, recently, I've been advocating for early feeding. Within 24 hours, you feed. Chewing gum, patient has started taking insulin, advocated.
Thank you so much, Dr. Francis. Members, kindly unmute to avoid interrupting. Thank you so much, Dr. Francis and Dr. Daniel. We are moving into the other agenda of this is from the experts on this matter, on this case of assessment, investigation, and management of acute abdomen. We are starting with Dr. Olinga Daniel. Yeah.
All right. So thank you very much, Mr. Issa, and the audience for the active interaction we are having. So much of our discussion is really going to help us even understand better how this patient presented. And so in an emergency setting, always when this patient comes in, the assessment is key for you to actually make the decisions that are going to follow thereafter. And in the package of assessment, you're having a primary survey, then a brief sample history, like it was presented. Then at that point, by the time you finish having your primary survey and your brief sample history, you should be having very many things that are running in your mind that will actually trigger you to have the investigations that are going to follow. So those many things are called differential diagnosis. So let me jump into the aspect of primary survey. This patient is going to come in with pain. Sometimes they may come alone or with attendants. So you as the health worker, you're not going to have the time to practice the traditional way of taking history. How many cats do you have at home? Did anything bite you? So we want to avoid that so that we manage the patient in a timely manner. So that's why we say we go through the ABCDE approach. So the patient is a whole, is just not the presenting complaint he has as the abdominal pain. So look at the airway. Sometimes he's complaining about the abdomen and yet he has started frothing and this can obstruct the airway. So ensure that he's talking to you and the airway is clear. Then look at the breathing, so the respiratory rate. These vitals in the respiratory system actually help you understand the severity of illness as well. For example, someone in pain will be tachypneic, so their respiratory rate will be higher than the normal limits, all right? Then if they're vomiting, for example, in our patient, sometimes they actually end up aspirating. And you want to have that listening to their lungs to actually know if they have aspirated some fluids. And this, if they aspirated, could actually predispose them to having hypoxia. And hence having your SpO2 reading done in a timely manner helps you initiate this patient on oxygen. Then you move on to circulation. That is assessing for the capillary refill, the pulse rate. Again, for patients who are presenting with acute abdomen, they will have a tachycardia, okay? You will look at their BPs. Sometimes they are overly dehydrated and the BPs will actually be low. So you want to resuscitate them by giving them IV fluids. And then listen to the heart sounds as well. Sometimes some of these conditions in the acute abdomen setting tend to come along with anemia, right? For every system that you go through, A, B, C, D, E, when you identify the problem, address that problem before you move on to the next. And so this brings me to disability. What is the level of alertness or consciousness of this patient? So we do either the GCS and AVPU. So, but what is simple for you to get at that point is the AVPU, where A is alert, G is verbal response to pain, then unconscious. So if the patient is talking to you, that patient is alert. Again, most importantly is the random blood sugar. When we looked at our patient, the management, yes, he was given some dextrose, potentially post-op, but if you look at key in the history, we had not eaten for 2 days, and this was a patient who was vomiting. So if you're anchoring into the pain of the abdomen, then you're going to miss the hypoglycemia in this patient. So I do the random blood sugar and address accordingly if it is present. Then you move on to exposure then. So exposure is where you identify other features that are culminating into the patient's presentation. So this range from the general appearance of the patient. Is the patient looking overtly weak, dehydrated? Are they having jaundice? Are they anemic? So when you've done that general assessment, get the temperature as well. The patient presented with fever. Okay, so this actually also tells you that potentially this patient who is presenting with a sudden onset of abdominal pain is also having a toxic event. And like Dr. Francis had earlier said, some of these features like appendicitis actually present with abdominal pain, but the patient is also toxic. So they are having raised fevers. Then you scale down to the particular system, okay? So the particular system is the abdomen, and you want to do a thorough abdominal exam, looking out for the expansion with respiration. Is it distended when you visualize, when you inspect it? Is it overtly distended? Is it scaphoid? Because sometimes you're having masses in this abdomen, and just by inspection, you can identify a certain area, or if you divide it into quadrants, a certain area that is asymmetrical, right? When you move into the next aspect is superficial palpation. So superficial palpation, you're trying to look out for any obvious tenderness, any obvious masses that could be there. Then deeper palpation is to look out for specific organs. And remember, when you're doing this, the patient is going to be in pain. And so that is where the analogy of giving analgesics is important. So back then we used to say, let the patient be in pain so that we don't lose the focus of the pathology. But believe you me, when you give this patient analgesics, when you reach that focus of pathology, you will still be able to identify. So give the patient the analgesic and examine the patient thoroughly. Gently percuss over that area, and within that percussion, so you can get percussion tenderness, or better yet, we understand it as the rebound tenderness. So that is where you will get. And guarding is not the patient pushing you away. So guarding in the abdomen is when you're palpating, the muscles over the pathology actually tend to become stiff and contract. So that is where guarding stems from. Lastly, we had a differential, for example, in the patient we had of intestinal obstruction. So auscultation also comes in handy. So in the initial phases, there is increased GI motility, but with progression of the condition, there will be a decrease. So you have to delineate what is normal versus abnormal. So that is your primary survey. And at that point, you're already having things that are running in your mind, okay? So as to just back up that feature of what is going on in your mind is where the sample history comes in. So sample S is symptoms. So the cardinal feature for acute abdomen. And just to make it clear, acute abdomen is not a given or specific standard like some other diseases, say acute liver disease, then they tell you maybe 2 months or 1 month, acute kidney injury less than 3 months. No, this is sudden onset of severe abdominal pain. So that is what the patient will cardinally come presenting to you with. I have this pain that is limiting me from doing various things. So then you explore into the abdominal pain. Onset, when did it start? Mostly it is sudden onset, okay? Yes, you might have had maybe 2 weeks prior of on and off abdominal pain, then this sudden severity just explodes. From 2, they're already at 8, 9, 10, because that is where you will scale them. They'll always be around 8, 9, and 10 in the pain scale. Then you also want to identify the location of this. So location in abdominal presentations, like the surgeons will agree with me, is sometimes vague. Shall not delve deeper into this, but it's because of where the anatomical innervations are. So it could be visceral pain, which is non-specific and mostly referred, okay? You can have parietal pain, okay? More of the parietal pleura. So that one is where you can actually localize the patient's pain. Then look at severity, okay? So the patient, yes, has come to you, but what are you looking into? Is it limiting your day-to-day factors? So the patient will tell you, I used to move even with my pain, swallow omeprazole, and I feel much better, but doctor, 2 days later, I was just bedridden. That alone in the history tells you that this is something very severe for this patient. Unfortunately, in our history, we didn't have the specific analgesics, but you have to look at some of the alleviating or relieving factors. So patients will tell you, I swallow analgesics like paracetamol and my pain goes down. Okay? When I don't swallow, it worsens. Another patient, for example, if you're thinking about pancreatitis, they'll tell you, when I lean forward, my pain actually goes away. So those are some of the factors that you also want to associate into this pain. Then you want to look into other features that he has come in with to a certain toxicity, okay? So if someone has conditions like PUD, for example, acute gastritis, acute peptic ulcer disease, the chances of them being toxic in the picture are very minimal compared to the patient who is going to come with appendicitis, cholecystitis. They will present to you with a history of fever. So they will say, I have fever. Then others might tell you, I have loose motion, so diarrhea comes in. I have vomiting, anorexia has come in. So alarm signs like passing bloody stools, melanoma stools. So those are the features you want to put together while you are managing this patient in the history. So while you've finished the symptoms, because it's the largest part, you also want to look into allergies. Potentially in our setting, many people go get into the traditional medicine and take herbs. Perhaps they're allergic to that, and that could actually perpetuate the condition for which they're coming with. So look into the history of allergies, the medications they have been taking. So if you know that the patient has a chronic illness, look into their panel of medicines they are taking. Because some of these medicines, like the antiretrovirals, the anti-TBs, could actually predispose them to some conditions like pancreatitis, drug-induced hepatitis or liver injury. So that history of medication is key. Do not forget to look into the past medical and surgical history. So while looking into the past medical and surgical history, have these symptoms occurred previously in this patient who is presenting to me with abdominal pain? Has he had any surgeries that have been done to him? So you're looking into potentially the complication of the surgery, they develop adhesions, and now they are presented to you because of that complication, right? Then L is last meal and last menstrual period. So if you're having a lady before you, it's important to know a last menstrual period. Why? Part of the differentials, as you can see, what is presented before you there involves ectopic gestation. So in the right iliac fossa is where you're getting an ectopic pregnancy. So you could be able to actually tell that this lady potentially could be having a ruptured ectopic or is having an ectopic gestation that is giving her the acute abdominal pain from the history of the last menstrual period. Because this will guide you into doing the HCG to actually confirm. Then the last meal, obviously it helps us to know about the glycemic control of this patient. So if they have come to you 5 days later, they've been vomiting, not eating, it is key for you to ask for that because it helps you in initiating management for this patient. Then the events are really what surround the symptoms that the patient presented with. So I had previously had the pain for 2 weeks. I went into this facility and I was given some medication. This helped me, but now I have presented with this. So you're getting a brief story for why now. Many people come with history, but why now is what the event caters for. So having had those two, the primary survey and the sample history, so you have a full package then of this diagram that has been separated into these abdominal sites, where you can actually start thinking of various things the patient could have presented with. So I'll not go through all of them, but I'll just try to look into the common ones that people present with. So normally we want to subdivide them into gastrointestinal. What is happening in the GIT. So the GIT starts from the mouth up to the anal opening. And then what is happening in the genitourinary system? So genitourinary system, we're looking at organs that let out the urine. So this is the penis for men, then the urethra for the females. Then you just follow back up, ureters and kidneys, so genitourinary system. Then do not forget the gynecological history. So that is how you want to, one person can subdivide them into that formulation. The other person can actually say, I'm subdividing my differentials into surgical or non-surgical. So non-surgical, majorly we try to say these are medical conditions that we may want to manage conservatively with other supportive drugs. Okay? So if you subdivide them into surgical, non-surgical, it actually helps you later, Dr. Francis will tell us, with regard to referral and disposition. Disposition is transfer of care to another specialty. If you subclassify them into that, you will actually know where am I sending my patient. But this full list actually caters for very many things. So let's start with the epigastrium. Someone comes in with abdominal pain, but it's more marked in the epigastrium. So you're looking at organs that are within that area. So it could be a worsening peptic ulcer, could be a perforated ulcer, it could be pancreatitis. So for pancreatitis, I hinted for you that it can be preceding some events like binge drinking of alcohol, and now the patient comes in with sudden onset of severe pain. And when they lean forward, they tell you, doctor, I actually feel better. But again, with pancreatitis, they tend to have nausea and vomiting. So the symptoms are really vague, they are non-specific. Because one person will say, whenever I eat, I also get nausea and vomiting, and the telltale signs are more on the gastritis or the peptic ulcer disease. So when you move to the right hypochondrium, those are the areas where we're having the liver mostly. So we're looking at what systems are formulating the liver. So the liver parenchyma itself, then we have the gallbladder, then you have the biliary duct or tree. So then you're having differentials like gallstones that will come in, so the patient will have pain. This pain can also radiate to the back. Like pancreatitis, it can also radiate to the back. What comes along with the gallstones? Patient will have a progressive yellowing of eyes. So this is part of the history that you pick, that progressively I have yellowing of eyes, because potentially if the stones were dislodged from their primary area, they block the flow of bile, and hence it accumulates later, and then the patient will start presenting with yellow discoloration. Cholangitis, inflammation of the ducts. Then you have hepatitis, again can be gotten from the drug history, so drug-induced liver injury, could be primarily from infections like hepatitis A. Then one of the things that we usually miss that can also give us severe abdominal pain is a liver abscess. And like I'd hinted to you, that patients who present with abdominal pain and they are having fevers tend to be more toxic. And so you want to look into the infectious causes of acute abdomen, for which liver abscess comes in handy. When you just slope down, you have ureteric colics. So this could be also triggered or stimulated by ureteric stones. So you're having spasms in that area and can cause actually severe abdominal pain. So down there are some chronic illnesses like Crohn's disease and diverticulitis that may present to this patient, and what accompanies them are perhaps loose motions, and sometimes they are accompanied with bloody diarrhea as well. But importantly in that quadrant, and I was impressed that approximately 80% of the audience was able to identify that appendicitis is the commonest presentation in the ED for acute abdomen. So whenever patients come to you, think of appendicitis, okay? Can be acute, because this is a redundant organ and it keeps on trapping some dirt, germs, etc., and eventually it becomes a culture media for organisms. And so this is why most of the populations, and it doesn't have age groups. Some of these differentials we have age groups. but appendicitis will occur to any age, provided they are having a process that is ongoing, a pathological process that is ongoing within that area. Then for ectopic pregnancy, again, another presentation in the age bracket of the reproductive females. So you have to look into the last menstrual period. You also want to do HCGs. The investigations are going to be told to us later. But what is peculiar about ectopic gestation? So it could be one-sided, either left or right iliac pain. However, when it ruptures, it tends to actually have referred pain. So when this patient has a ruptured ectopic gestation, they tend to have their pain referred to the right shoulder. So if you get patients who are having such features, also know that that could potentially be one of the issues that they are facing with. Then for the males, down here, an analog could be testicular torsion. So from the origin of the testis, they normally come from up here, they still have their innervation getting back into their abdomen. So while the torsion is ongoing down in the scrotum, the patient will actually present to you with severe abdominal pain. What would accompany that is vomiting. So it's important in your examination or secondary survey then to also try to examine the testes just to ascertain that this patient does not have testicular torsion. So I've mentioned variety of these. Others that might not be here are actually malignancies. So you could be having tumors in the head of pancreas. You could be having tumors in the colon itself, and the patient is progressively having this severe abdominal pain. Could be HCC, could be also a tumor in the liver. So there is a variety of symptoms that the patients will present with. For the surgical bit, you're having patients coming with intestinal obstruction, and then in the history, you want to look out for peritonism, so signs of peritonitis, because most of these differentials that we have mentioned will actually culminate into a patient having a complication of peritonitis, and this is surgical. The surgeons normally have to get in and help us arrest that issue. Trauma is another, so you have splenic ruptures that can occur as a result of trauma. So all these will come in with the presentation. Cardinal feature is acute abdominal pain that was of sudden onset and is severe between 8 to 10 in the pain scale. So that is severity. And remember to always delineate toxicity with other features that surround that. So briefly, that is on the assessment and the differential diagnosis that you will have. Thank you very much.
Thank you so much, Dr. Daniel, for the presentation. And I'd love to go to Dr. Francis.
Thank you, Mr. Hissa. Thank you, Dr. Daniel, for that elaborate presentation. Briefly, I'm going to talk about the diagnosis, but important to note that the diagnosis is dependent on your knowledge of the anatomy. The information that we have on the slide, you note that most of the organs whose origin is from the foregut, the pain is more or less within the epigastrium and the hypochondria. Then if you move to the organs that are from the midgut, just from the mid-duodenum to the cecum, the pain is more within the hypogastrium. Then when you move to those which are from the hindgut, where we have the large colon, then the bladder, the pain is more within the suprapubic region. So for diagnosis, it's important to have the anatomy, because that alone gives you a hint where the pathology could be. Now, like for the pain in the epigastrium, from the pictures that we have, there are a couple of things that you can look out for. However, important to note, for the diagnosis, before you even rush to the investigations, the clinical presentation and your physical exams have a lot of information. Actually, you can have your diagnosis up to 90% certainty just with the clinical presentation and a thorough physical examination. So for the diagnosis, there are some of the features that we look out for. For acute abdomen, we as surgeons, we are most worried of that presents with colic pain or with features suggestive of peritonitis. So each time we see peritonitis, we kind of get worried. So briefly in the diagnosis, there are some signs which are known, and they are kind of suggestive at least of a particular pathology. One can be a Canet sign. Remember, we are looking at acute abdomen of any cause. Trauma alone on the abdominal wall can cause acute abdomen. A patient can present with acute abdomen. You need to tell, is this pain, if there is maybe a history of trauma, a patient who has been on anticoagulants, can present with a hematoma on the periabdominal wall. Canet sign, you can tell a patient to, as you're palpating, you can tell a patient to kind of try to sit in a same seated position. If the pain increases, that alone suggests of a pain of abdominal wall origin. If there is a decrease in that pain, then definitely the pain is within an intra-abdominal cavity. There is a Murphy's sign, suggestive of acute cholecystitis. Patient presents with a pain in the right hypochondria, and you think this patient could be having acute cholecystitis. You can tell a patient to take in a deep breath, then you palpate in the right hypochondria at the tip of the knife intercostal space and tell them to exhale. Normally they tend to hold that breath because of the pain. That alone can be suggestive of a cholecystitis. Then for appendicitis, we've noted from the, actually one of the commonest causes of acute abdomen in an emergency setting is appendicitis. The presentation at first is vague. Remember, he talked about the visceral pain and the parietal pain. For a visceral pain, this patient will present with pain around the periumbilical pain at first, which later on localizes into the right hypochondria. So that migratory pain alone can suggest something. There are also signs like the Loving sign where you palpate in the left hypochondria and the least rebound tenderness in the right hypochondria. Still, that alone can suggest
Canet sign. The Canet and then the Murphy's sign. More like a Canet sign.
Okay. Murphy's sign, then we can have a Loving sign. Someone palpates in the left iliac fossa, and the least pain in the right iliac fossa, rebound tenderness pain. Still, you can, yes, that alone can be suggestive of appendicitis. There are also other signs like the obturator that we can look out for, the psoas sign. For the psoas sign, that can also be suggestive of a retrocecal appendicitis if it's on the right. We can also have a psoas abscess. So anything that influences the psoas muscle can cause, anything that affects the psoas muscle can cause a positive psoas test. So we are going to read, note the psoas test, the obturator test. Yes, we can do some reading up around that. Then the issue of colic pain. A patient comes in with an intermittent pain. The pain is on, it comes in a wave. It's common in a dynamic gut obstruction. Like if you've just had a volvulus, oftentimes that patient will present with a colic pain, the pain which is on and off. It comes in a wave, then after some minutes, it will cease. The patient might be okay for some few minutes, then it comes back. But important to note, this pain might at times progress to a continuous pain. That's if gangrene is setting in. So for colic pain, that alone can tell you that possibly if it's of gut origin, this gut is still viable. So that has a lot in your decision making, because these are patients who would love to go in as fast as possible. If you're in an emergency setup where you have access to theater, these are patients who wish to resuscitate as early as possible, go in. Then you can also have the biliary colic. Important to note, much as reported as a biliary colic, this pain can be there for over 5 hours. Actually, there are cases where biliary colic has been reported to go up to 24 hours. It's a colic pain, but it can be a prolonged colic pain. Someone presents with pain in the right iliac fossa, in the right hypochondria of colic in nature, prolonged, think about biliary colic. Then you can also have a renal colic, just like we've seen in the differentials. The pain comes in a wave. It's on, after some time, you see that the patient is literally normal. The patient is almost normal. So just from the anatomy and a physical examination, there is a lot that you can make from the diagnosis. Then the signs of peritonism are important, the rebound tenderness and GERD. When you're listing the rebound tenderness, it's a painful procedure. Actually, recently we've resorted into using a stethoscope. You kind of tell a patient, I'm listening to something. And doing that, as you scouted, you can elicit rebound tenderness. Because it has been found that even with percussion, the pain normally is unbearable. Yes, then for our children, because of their discomfort, you can tell them to kind of stand on their toe and tell them to fall back. With that, you can see them moving their hand where the pain is. You can tell them to cough. That alone can also list signs of peritonitis. Note, peritonitis is not a good sign in an emergency situation. On the diagnosis, lastly, any pulsatile mass. Because there is a possibility of having an aortic aneurysm. And some of these patients might present with a ruptured aortic aneurysm. So the ABCDE is important. Diagnosis, we have a couple of diagnostic modalities. In most of the emergency units, we have the eFast. Make use of it. At least if the services are there, let's get into a habit of learning these few techniques. You can do a simple ultrasound scan. You can easily see free fluid in the abdomen. That alone can save the situation. Because you can be in an emergency unit where you don't have a radiologist nearby. So an ultrasound scan is handy. And I think for those who have an opportunity to access the service, it's always better you learn the basic ultrasound scan technique. You can easily note some mass in obstetric case where you suspect that this patient could be having an ectopic or free fluid in the abdomen. Then a chest X-ray for suspected perforation. Much as in our patient, because of the financial constraints, doctor told us they did an abdominal X-ray. I think they were deliberate. Sometimes we tell, when we are not certain, we tell them to do an erect abdominal X-ray and pick the hemidiaphragms as well, so that we don't do two images. But for suspected perforation, where funds are available, let's do an erect chest X-ray. Abdominal X-ray in suspected obstruction, where we have services which are modern, we can do a CT scan. Then the labs, radiographs, are CBC is important. We noted in our patient, we had a neutrophilia and a leukocytosis. We had a neutrophilia and a leukocytosis. So that alone shows that this patient is becoming septic. So that the patient has a septicemia. So that alone tells you the possible cause of an acute abdomen. Liver functional tests and renal functional tests, some of these patients might present in shock. So pick the urea, pick the creatinine, liver functional test. For a patient who has been sick for some time, like for a patient, you noted that he had a tinge of jaundice. I don't think this jaundice is related to the ARVs the patient was taking. He had been on these ARVs for close to 8 years. So do a liver functional test, and where possible, resuscitate it as early as possible. In cases where you have theater, it's good rushing these patients, but resuscitation is very important. We've had bad results where someone comes in because you've made a diagnosis before proper resuscitation, you rush to theater. Even in facilities without theater, first have these patients resuscitated so that they are fit for transfer. We can have surgical emergencies, but some of these emergencies can wait. At least they can give us some time to do some good resuscitation. Make sure that this patient is well rehydrated. Make sure that if there is, at least the patient has a basic CBC, not the hematocrit, in cases where you have the HB. Yes, not in cases where you at least you're able to access the CBC, where you suspect anemia, get the HB, get the hematocrit, MCV, MCH. They can easily help you make a diagnosis. Where you suspect an obstruction or perforation, hold orphans. Like Dr. Daniel said, this habit of not giving patients analgesia because you feel it might obscure the symptoms. If the symptoms are there, with or without analgesia, the pain will be there. For surgery, don't wait for, when suspected gut obstruction, don't wait for this gut to get gangrenous. We've had cases where someone diagnoses a sigmoid volvulus or a compound volvulus. Someone comes in with colic pain, and all of a sudden someone still gives this patient another 12 hours. That alone worsens the situation. Where you're not certain, resuscitate, refer to a higher center for proper assessment and management. Thank you.
Thank you so much, Dr. Francis, for that presentation. For the participants, the floor is open now. We are going to the question and answer session. You can ask your question and the experts will be able to respond. You can either raise up your hand or type in the chat. Yes? Hello? You can raise up your hand or type and ask your question. This William Mawanda, when do we decide to manage acute cholecystitis conservatively and surgically? Dr. Francis.
I don't have.
Acute cholecystitis
Conservatively and surgically.
If the cause of a cholecystitis is a cholelithiasis, a patient comes in with a history of a cholelithiasis, a gallstone, and features suggestive of a cholecystitis. Oftentimes we manage the cholecystitis and preferably do the surgery at the same sitting before we decide this patient. So, in suspected cholecystitis due to a cholelithiasis, do a cholecystectomy. But after giving some antibiotics, preferably after 48 hours.
Okay. Thank you so much, Dr. Francis. We have the Commissioner, Emergency Medical Services, Ministry of Health, Uganda, Dr. J.B. Onyai. Doctor, you can greet the panelists and the participants. Welcome, Doctor.
Yeah, thank you so much, moderator, and all the doctors who have given us the clarity on acute abdomen as a common cause of emergencies. And all the participants who are on. I am on the road traveling, but I want to thank so much for always getting time to really educate our frontline health workers. It is very important, and I've seen usually when I was in medical practice, acute abdomen was a big cause of mortality, and I think it is even up to today. And getting additional skills is very key, especially for people who are working at the lower units where most of this condition is starting from the health center falls, then hospitals. You find that even if you are a medical officer, you may not feel very comfortable with handling acute abdomen. So I want to thank you, the Dr. Daniel, for the introduction, and Dr. Kakoza for the moderation, and all the other team members who have made the
Doctor, the network is not good. We can't hear you. Hello? Hello, doctor. Okay. That was so good from our commissioner. We can go on to the Q&A session. Dr. Francis had already answered one. Yeah. The other question from Brian Musoti. From Brian Musoti. From the case, what was the rationale for giving 50% dextrose? Dr. Daniel, can you respond?
All right, thank you very much, Musoti. Musoti, yes, thank you very much. So the dextrose was largely given post-op. And remember, after the patient was operated, he has to go nil per hours without eating anything. So we want to give baseline glucose to just give him a baseline level of glucose in the system. Since we are not having any intake, we know the best route for always getting glucose is orally. If you go into starvation, yes, the body then starts to break down its stores to generate for you glucose. But for this particular patient, he received his dextrose post-op as part of maintenance.
Okay, thank you so much. Olympia Tombe, thank you for the presentation, doctor. What was the basis for using 3 different crystalloids? Would the RBS contribute to the type of fluids we would need to give? The question is, what was the basis for using 3 different crystalloids? Then RBS wouldn't contribute to the what? To the management of growth. Saying, would the RBS contribute to the type of fluids we would need to give? Dr. Daniel can respond.
So thank you for the question. It's non-specific, but let me approach it in this way. So the debate of crystalloids will continue raging on saline versus Ringer's lactate. Accurate maybe if you have your electrolytes at that standpoint, but if you're down there in the lower health facilities, use what is available for you. Use either Ringer's lactate or normal saline. Then to chip in into the point of RBS, like I'd emphasized in your primary survey, it's important for you to get the random blood sugar or glucose level at that point, because that is what helps you to decide if you can add some dextrose into the fluids you're giving this patient. So as part of disability, always do random blood sugar. Thank you.
Okay, thank you so much, doctor. John Bosco, Namkoa, why would a patient with gastric perforation have bilious vomiters? I think that was answered. That was answered by Dr. Francis. We can go on to the other question. Shafar Umar, why the antibiotics? It is usually sterile. Acidic fluid. Dr. Francis, do you have a response for that?
We have, when we go to types of wounds, we have the clean wound, we have the clean contaminated, and anything that goes through gut or urinary tract that qualifies to be a clean contaminated wound. Actually, for this particular one, it's a dirty wound. Actually, it's a contaminated wound because we are having direct spillage from the GIT to the peritoneal cavity, which is supposed to be sterile. So there are high chances of developing surgical site infection with intra-abdominal abscesses if you don't give antibiotics. So this is a contaminated wound.
Okay. Thank you so much, Dr. Francis. Trevor Biamukama, after how long should the patient continue or start oral feeds post-surgery?
Like I said, we are moving away from starving these patients for so long. And previously, these patients would spend close to 24 hours. But with practice has shown that even after 36 hours in PUD perforation, we can initiate feeds onto these patients because hypoglycemia has a bearing on wound healing. So we'd love to have these patients at least with the normal glucose levels. Then the issue of ambulation. For a patient who is hypoglycemic, it's always hard to tell them to ambulate. So we'd love to make them eat as early as possible, to start sips as early as possible. It's the same thing with the issue of drains. There are a couple of things that we are going away with. As long as you've done your good lavage, go with drain. For as long as you feel the surgery was clean, allow these patients to eat as early as possible. Within 36 hours, you can let them eat.
Okay, thank you so much, Dr. Francis, for that response. Mawen M. Arik, do you consider Ogilvy syndrome to be cause of acute abdomen in HIV patient? And how common is it?
So Ogilvy syndrome in HIV patients is really a rare condition. However, it might give you some mild to moderate features of abdominal pain. So it's something that you might not want to consider, but it's a differential diagnosis.
Okay, thank you so much. Dr. Zoe, what are the indications for gastric decompression by NG tube in acute abdomen? Dr. Francis?
Gastric decompression indications.
Yeah, the indication. What are the indications for gastric decompression by NG tube?
For acute abdomen, for perforations, like a PUD perforation, we want to minimize the amount of, remember, with or without a perforation, the gastric will continue secreting gastric juices. So we'll have to minimize the amount of fluid within the stomach to give time to where we put a patch to heal. Then in case where we have an obstruction, remember things are not proceeding this time. So the only alternative is to drain them out. Yes, out.
Okay, thank you so much. Safa, 1999. My question is, how can I differentiate organs in same site in abdominal region, and the patient comes acutely in pain? How can I differentiate organs in the same site? I think the main question is, how can he or she differentiate the organs within that specific region? Yeah.
So I'm differentiating. So the question is really telling me, how can I identify that this is specifically acute pancreatitis? And I think the answer stems all the way from history. The moment the patient starts presenting to you with specific symptoms, there are those symptoms that are pointing towards organs. But if they still remain non-specific, you still have the allowance of actually carrying out the investigations that Dr. Francis talked about. For example, the ultrasound scan will be able to actually show for you an inflamed appendix, can be able to differentiate for you gallstones. If you do x-rays, the left abdominal will be able to show you that gut is perforated. Better yet, if there are ureteric stones, you'll still be able to pick them out. So identifying a specific organ starts from history. I have abdominal pain, relieved by leaning forward, acute pancreatitis, so acute and chronic pancreatitis. So it's really the holistic package from history until you have your investigations done.
The other question is from Wen M. Arik. What is the first line investigation of choice for acute abdomen according to the guidelines? Is IFAST recommended in all acute abdomen? Dr. Francis?
We are managing acute abdomen in an emergency setting. You should have a highest index of suspicion, at least for a particular illness, depending on the differentials that you have. Within our setup, one of the easiest investigative modality in terms of imaging is the ultrasound scan. It's accessible and it's not kind of sophisticated. So depending on the diagnosis, important to note, most of the diagnoses that we have can easily be picked by an ultrasound scan. If you have a perforated PUD, you can, and one of the differential, you can easily notice free fluid. They can even easily notice ileus. If you have appendicitis as one of them, you can easily. If it's an appendicular abscess, they can easily pick it on ultrasound scan. If it's an acute appendicitis, they can easily pick the inflammation. They can easily pick the periappendicular fluid. If it's an ectopic pregnancy, so in our setup, the easiest treatment, the easiest modality is an ultrasound scan. In developed countries, they can easily rush for CT scans. But in our setup, normally, it's more of a luxury.
Let me just add in some. So just on top of what Dr. Francis has mentioned, so he asks about an EFAST, the EFAST. So EFAST is also ultrasound, only that it's extended focus assessment of sonography in trauma. So the emphasis there is trauma. So if a patient has come with an acute abdomen and you're suspecting hepatic lacerations or splenic lacerations, that is when you want to do your EFAST. But the others are point of care ultrasound scans, which Dr. Francis has really elaborated on.
Okay. Sema under David, in appendicitis, can it be managed supportively in case there are no masses?
The only indication for non-operative management of appendicitis is if you have an appendicular mass. But still, you have to go and do an intra-appendectomy later on. If you have an acute appendicitis with no masses, it's not a surgery. Okay. Still, even in the appendicular process, the previous teaching was you drain the pus and do intra-appendectomy. Recent studies have shown that you saw it's better you do an appendectomy at the same sitting as you drain the pus as well.
Okay. For the people asking for the CPD link, it will be shared on the screen. Just kindly wait. From Caroline Nampeo, elaborate, kindly share about volume resuscitation in acute abdomen. Say patient is in shock. Like if the patient is in shock, kindly share the amount of volume you can use in the resuscitation. I think it's all about the volume of fluids used to use in it if a patient has gone into shock. Yeah.
So management of shock in these patients of acute abdomen is case-to-case based, and it is also informed by the vital signs that the patient has during that period of shock. And some of the vital signs that we look out for are altered mental status, we look out for urine output, and then mean arterial pressure. So the initial bolus that you want to give for these patients in shock is 10 mils per kilogram of body weight. Reassess with baseline parameters that you started with. Is the mean arterial pressure improving? Is my patient getting less confused? Is the urine output getting better? Because your target now when the patient is in shock is at least 1 mil per kilogram per hour. So is that also improving? If that is not yet met, you can move on to achieve. You add another 10 mils per kilogram of body weight to a maximum of 30 mils per kilogram of body weight. Then you can think about other interventions. If the patient has persistently been there and they are having a septic picture, you can bring in vasopressors and also blood transfusion.
Okay. From the charts, Basiga Amos, what are the chances of anastomotic breakdown in patients who started feeding within 24-hour post-operatively? What does the evidence-based practice suggest, Dr. Francis?
I don't have the exact figures, but this is out of experience. Leakage really depends on when a patient started feeding. It's normally the technique or the decision made intraoperatively. You've had severe soiling, you're not certain of the viability of the gut, and your anastomosis. Definitely that will cause a leakage. But feeding per se, for as long as the patient, the gut motility, evidence of gut motility is there, oftentimes the chances of leakage are minimal.
Okay. Thank you so much. From Catherine Akanuaji, back to the question on management of cholecystitis, surgical versus medical. Any experience on use of PO, also deoxycholic acid for patients with cholelithiasis? Dr. Francis, do you have a response for that? Not really.
I think she's talking about also deoxycholic acid.
Yeah.
And this is really used when the bilirubin levels have gone up. It is part of the supportive management when we are not going to intervene surgically. So because of the high bilirubin levels, you want to bind most of them so that you reduce on the side effects the patient will be having, for example, itching. So that is why we give also deoxycholic acid.
Okay. There was a question on.
Hello, sorry. Excuse me.
Yes, please.
Thank you very much. This is Dr. Nakanaji Catherine.
Yes, please.
I thank you very much for the presentation and for the question. Just to go back, I remember reading somewhere that ursodeoxycholic acid also has a role in dissolving the gallstones. So I just wanted to find out whether, you have any experience in using it, and also, for that purpose, apart from the one you've mentioned. Thank you very much.
You're welcome, please.
I've not had a chance to follow up on the patients that have been, but I've noted that it's normally given in patients who are frail, patients that you feel cannot easily withstand surgery, or who have other comorbidities that can at least not make them withstand surgery. And I've also noticed, without giving figures, the exact millimeters of the stones, but they are often used in smaller gallstones. But for larger stones, oftentimes require surgical intervention.
Okay. I think Dr.
Okay, thank you very much.
Okay, please. The CPD link. Yeah, I think you have seen the CPD link. Then for those ones who are asking for recordings, there's always a link shared which has the previous echo sessions that we have had, both recordings and the videos, the audios and the videos. You can just visit the web, that link, and then access all the previous sessions that we had. Dr. Francis, do you have another? Okay. I think we have exhausted the questions. I don't see any more other question. Just allow me head forward to the other agenda. I would love to have the closing remarks from the panelists. And let me start with myself. I must say it was a very, very good session. And thank you so much, our experts, for the knowledge that you have imparted to the world, because this session was attended from different places and around the globe, people even beyond Uganda. I would love to extend my thanks to the Ministry of Health, Uganda, and particularly the Emergency Medical Services Department, our dear Commissioner, Dr. J.B. Waniaye, the CD Global Health, who have made sure this session stands, and who have really done it a lot for us to get the knowledge so that we can improve the health of our people and our patients as a whole. For the ECHO coordination team, thank you so much for the job well done. May God bless you for that. For my members from Mbari region, under the coordination of Dr. Stephen Emmanuel Apollo. Thank you so much for the job well done. My colleagues, Augustine, Isaac, and my people from Sole General Hospital, please, thank you for attending, and let's continue with that good heart of serving our nation. Thank you so much. I think that's all what I have to say. Let me head forward to Dr. Daniel. Please, I want you to give your closing remarks. Thank you so much. Okay, members, I'd forgotten the post-test is running. You can be answering the post-test. After finishing to answer, you submit in. Okay, you can proceed. Dr. Daniel, you can proceed.
All right, thank you very much, moderator and organizers of these eco sessions, and to the audience for really attending. I'll just remind us that amongst the common presentation in the ED emergency department, with fever, headaches being one of the commonest, acute abdomen is one that you'll always come across. Please remember to always approach your patient with the quick primary survey and the sample history. Have a very rich differential list. Have as many as 20, because you can get surprised. Sometimes what you think moves like a duck, works like a duck, it might actually be a swan and it's not a duck. So have a rich list. Then lastly, following your investigations, some investigations can be done bedside, others may not be in your facilities. So speak to the referral units, speak to the emergency medical services, consult the unit you're going to refer to so that you get in touch with the surgeons or the specialists for these specific conditions. And do this in a timely manner. Once you've stabilized your patient, please refer them to the higher facilities. You won't get stuck with this patient because they will surprise you. Again, thank you very much for attending, and we hope your practice gets better and better. Thank you.
Thank you so much, Dr. Francis. You can.
Thank you, Mr. Hissa. Thank you, the project coordinators, and thank you, Project ECO, for this opportunity. And thank you, the audience, for attending. One thing, medicine is changing a lot. Read as much as possible. What you thought worked 2 years ago might not work today. Seek for knowledge. Read as much as possible. In case there is an opportunity for such sessions, I encourage you to attend. That one word that you might pick might be the difference between life and death for your patients. Thank you.
Welcome so much. Thank you so much, Dr. Francis. And I think we are going. Dr. Sally. Dr. Sally.
Yes, please.
Yes, yeah, you can key in your closing remarks.
Thank you very much.
Yes, please.
EMS and coordinator of all sessions. We're very much happy about these sessions. They impact knowledge and helps us to improve in our clinical practice and handling of our emergencies. Thank you very much, team, and all the participants.
Okay, thank you so much. We are almost reaching the end of the session. Members, I think you're doing your post-test. Once you're done, just submit the test. I think we are going to take a screenshot. Sorry? I will ask Dr. Thomas to come and take us through this, the screenshot.
Thank you so much, moderator, and thank you participants for sparing the time, the airtime, and the data to attend EMS Echo sessions. We are always excited to see you participate. Regardless of our hiccups, you always persist on and attend. We hope these sessions are impactful and they improve your patient care. We are doing a general assessment of how the session was. So please go and rate Mr. Hisa Malijani. If you are giving him a 1 out of 10 or 10 out of 10, we'd love to see how you rate the session, because such ratings help us improve. And if you have any comments, please use any of the email addresses that we use to share with you the messages, or you can use info@emsecho.ug to send in any of the comments. For the certificates, those who joined in later, we are going to give our certificates in the coming weeks. The link for the certificate form was shared to those who are eligible. We said eligibility is attending 5 out of the 7 sessions. And for this phase, which has 14 sessions, please try to attend a good number. I think this time we shall give out a golden certificate because the sessions are many. We would love to see you again in 2 weeks. But before we go, we can take a screenshot, and as usual, you can access most of these materials on our website, which is www.emsecho.ug. That's simple. Or when you go to YouTube, you can just put EMS Echo Uganda. You'll be able to locate our recordings. Thank you so much. But before we switch on your cameras, we would love to share with you the results of the polls, and then the experts clarify on what was the right answer and why the right answer was right. Okay, I hope we are able to see the post-test results on our screen. Are we able to see?
No.
So for question number 1, the statistics have increased to 89%, and appendicitis was yes, it was the right answer. The question was saying, which of the following is the most common cause of acute abdomen in the emergency medicine department? So it is appendicitis. Question 2, it was saying, which of the following imaging studies is the most appropriate for patients with suspected acute cholecystitis, and 78% of the people chose ultrasound, and yes, the correct answer was ultrasound. So people have been paying attention, the stats have increased. Those of you who chose CT scan, a CT scan is not readily available, and you need some preparation to do, especially when you're imaging the abdomen, different from the head. The head you can just rush in and do, but abdomen you may want to do to give contrast here and there. So ultrasound remains our modality that we have to go to. And then question number 3, if we're saying which of the following is the most common, is not a common symptom of acute pancreatitis, and 73% of you chose bloody diarrhea, which is very true. A small percentage chose jaundice. So the answer is bloody diarrhea. Maybe those of you who didn't get it right, you can go through our recording again, or just do a small Google search to find why the reason is so. And for question 4, it was asking about physical examination findings suggestive of a surgical emergency. And the answer was rebound tenderness. This was answered right by most people, 91%. So people have been paying attention to this one. I am glad that most of us got the right answer, and if we didn't, please, maybe you can go through the recording again, or you missed it somewhere, but we appreciate all your participation, and most people have ranked the session very highly. Thank you so much. We'd love to see you in 2 weeks. Those that are attending as a group, I am seeing Team Kabale, unmute and greet us. Those that are in a group, Chimuli Joakim from Kabale, you can unmute and tell us, greet us. Whichever team is attending together.
A&E Fort Portal Regional Referral Hospital.
A&E Fort Portal Regional Referral, we can't see you. Those whose cameras are off, we can't see you to appreciate you attending as a group, but we appreciate your participation in such sessions.
They always sit together.
Team Yumbe, we are happy to see you. Please, if someone has a comment, you can just unmute and give us a comment. The session has come to a close. Have a nice weekend. All right, bye-bye, everyone.
Because we have the qualified. But let's not worry about it. So, to summarize it, we made the health together. Said number of students who start like half.
Thank you, everyone. Bye-bye.
Okay, you have taken the picture.
Team Yumbe, happy to see you. Bye-bye.
Thank you. Thank you so much.